Okay, I will be slowly starting. Hi everyone. My name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and I co-chair the sessions of the Targeted Neonatal Echo Foundation curriculum of the Neonatal Hemodynamics Research Center with Dr. Daniel Rios. And today it is really a great pleasure to welcome Dr. Rachael Hyland, who has accepted to present on atypical acute pulmonary hypertension in the context of these sessions. The first part of the presentation will be open to everyone, where we will have a didactic review of the topic, and then we will then follow to another Zoom meeting for our fellows and panelists in order to do a case-based presentation. In between both, there will be the opportunity for the audience of the didactic teaching to be able to participate in a Q&A. So please do not hesitate to put some of your questions in the chat so that we can address them for the few minutes between the two sessions. For our fellows and panelists, there will be a Zoom meeting that will be sent to you, another link in the chat in order to attend the second session, which will be case-based and will be presented by Dr. Numra Alim, who's the current Hemodynamic Program Fellow in Iowa under the supervision of Dr. Hyland. So just a few housekeeping elements. We want to thank Mallinckrodt Pharmaceutical for their support through unrestricted educational grant so that we can have these sessions. This is a session that is accredited by the Royal College of Physicians and Surgeons of Canada for CME credits that you could collect. And I would like also to mention that it's very important for us to obtain your feedback and your evaluations. So please take the time at the end of the session to scan this QR code and provide us with some feedback so we can really adjust the content of these sessions so that it tailors the need to our audience. I also want to thank Laura Thomas, who's in the background, but really takes a lot of time in orchestrating these sessions and allowing us to have these wonderful discussions with our guest experts. So on this note, Dr. Hyland, thank you so much for joining us, and I will have you share your screen. And I think you can start.
Okay, perfect. Sorry, just making sure everything was unminimized. Okay, and Gabriel, you can see the slides okay? Perfect. Thank you for that kind introduction. Yes, thank you to you and Laura and Danielle for all the work behind the scenes for this session. So we're going to get started. As Gabriel said, my topic that was given to me was atypical acute pulmonary hypertension. I'm just referencing the pre-readings. If you had time to review these, great. If not, also fine. We'll kind of talk through things in detail today. But even if you didn't get a chance to read them, I would suggest if you have time, I found both of these really helpful, especially the purple book, which is the second reading for you is super helpful when going through this physiology. I don't have any conflicts of interest to talk about, and we will be discussing some off-label uses of medications in the case discussions in a couple slides. So today, with the new format, as Gabriel said, of the educational series, we'll try to keep this lecture portion relatively brief and painless. We'll have time, like you said, for a general Q&A, and then one of our current Iowa Hemodynamics Fellows, Dr. Numra Alim, will present a case for us that illustrates some of the concepts that we'll cover in this lecture portion. So to start, I thought we should address the way this topic is presented. And I thought, maybe it's not quite fair calling the types of pulmonary hypertension we'll be talking about atypical, but regardless, if that's our starting point, maybe we should back up just for a moment and try to define then what are we talking about as typical. So taking that step back, let's maybe first define what we mean by pulmonary hypertension. And for that, I'm just going to cite the 6th World Symposium on pH. And as ever, we know this is geared towards adult medicine, but as ever, we're always extrapolating for our neonates. The definition defined at this conference is a mean pulmonary arterial pressure of greater than 20 millimeters of mercury, which used to be 24 and now 20. But as they clearly recognize in this quote that I pulled, like a value in isolation alone does not capture or characterize a clinical condition, right? And it certainly doesn't tell you anything about the etiology or the pathology behind it. This definition of a pressure greater than 20 was generated from cath lab data from over 1,000 healthy adult subjects, where they found they had a mean pulmonary pressure of around 14, and they just took 2 standard deviations above that. That's 20. So mathematically, they landed on this number of greater than 20 as abnormally high. Now, again, as emphasized by the quote, it's really important to recognize that pH is actually probably like a collection of diagnoses, and that the etiology for that underlying elevated pulmonary pressure is not always the entity of pulmonary arterial hypertension. Pulmonary pressure is generated by the equation pressure equals flow times resistance plus pulmonary capillary wedge pressure, surrogate for like LA pressure. And any component of this equation, so not just resistance-driven pulmonary arterial hypertension, but also increases in flow or in LA pressure, all of those things can generate disease and elevations in pulmonary pressure. And the adult literature like understands this and is going through it, and they break down pulmonary hypertension into 5 kind of general categories of pH. And you'll notice for our neonatal patients, we get one little line in there in this table for persistent pulmonary hypertension of the newborn. But what I'd argue is that while, yes, there's certainly this phenotype of arterial acute pulmonary hypertension that's very specific to and affects our babies, and that we're all quite familiar with treating, there are still variable other phenotypes that affect our infants, just as there's variability in this very long list of pH etiology in adults. And that's then what I think we can come to and call our, if not atypical, at least our kind of other forms of pulmonary hypertension that we're going to focus on today. So to define these other phenotypes, I'm going to be a little bit more simple, and we're just going to refer to that equation I referenced earlier. So pressure is flow times resistance plus pulmonary capillary wedge pressure, or LA pressure. And we can just break down neonatal pH into each of these categories. So while typical pH probably is referring to what we think of as PPHN or acute arterial pH, there are also then these other phenotypes that result from changes in flow and from the postcapillary or the left heart disease group. And I think too, it's worth a brief departure just to talk about our nomenclature now. So, and you can see I put a big red X through poor PPHN. So historically, what we're trying to get at with that diagnosis, persistent pulmonary hypertension of the newborn, that word and that diagnosis, we use it all the time, but it's probably maybe sometimes misused or misclassified. And it's really not the most accurate way to talk about even those babies that we are trying to refer to. So, here at Iowa and at many hemodynamic centers, we're trying to get away from that nomenclature of PPHN and instead refer to pH in terms of its phenotypes and then subclassify by its chronicity as acute or chronic. So that classic PPHN, maybe we could more accurately refer to as acute arterial pulmonary hypertension. And this is important, like each of these different phenotypes are managed differently. Not only is it important to communicate with each other accurately and not lump all these various different categories into the same diagnosis, but it's important in our management, as we're going to come to in later slides. So in this talk, we're going to focus on this bottom half. We're going to talk about the world of flow-mediated and left heart-mediated pulmonary hypertension. Because you already had a wonderful lecture. Dr. Sharon Moore talked about arterial pH in a talk, which should be posted now on the NHRC YouTube channel. She reviewed fetal circulation and normal transition and physiology, and really covered in expert detail all of acute pulmonary arterial hypertension. So I would refer you to that for that section. And we get to skip right over and dive into our 2 phenotypes, as I alluded to. Before I show you my relatively simplistic diagram of how I think about and conceptualize these phenotypes, I'll just refer you to this lovely figure that I'm sure you can all guess is drawn by the excellent Dr. Lakshmani Narasimha. It came out earlier this year in the editorial preamble to a Clinics in Perinatology issue on neonatal pH, which was co-edited with Dr. Abeman. I hope you've also had a chance to look at this. It's a brief introduction, but they very nicely and clearly lay out the same formula that I've shown you, shown here in this figure, and they introduce each of these phenotypes as well. So here's my version of that figure, a little more simplistic, but I really think this concept is important, especially for our own trainees. So we're hemodynamics trainees, but you're also explaining all these concepts to your students and residents. And I think it's one thing to be able just to say the phenotypes, but it's another, I think, to really understand and to be able to differentiate them. And for your learners, I think that drawing this out helps to clarify the physiology, because not only, again, is this important from an academic perspective, but truly our management of these phenotypes is really quite different. And sometimes, it's going to be directly opposed to the way that we're going to manage and treat pulmonary arterial hypertension. And I think, again, understanding the physiology, as we'll lay it out in the next few slides, makes understanding why we manage it differently really clear. So in this figure, I show the lungs and the pulmonary capillary bed in the center. And then in blue is the RV, and then the pulmonary artery, and then exiting the lung in red is the pulmonary veins to the LA. So that classic arterial pulmonary hypertension is disease that is resistance mediated in the arterial side of the system, while flow-mediated pH affects overcirculation to the lungs or to the right heart. And then the left heart phenotype refers specifically to pH mediated by the venous or post-capillary bed side of the circulation. And we'll start by this first category, flow-mediated pH. So flow-mediated pulmonary hypertension, as its name describes, is driven by excessive flow from left to right, either intra or extra cardiac shunting. So if you flood the right heart and lungs with more and more fluid, they will ultimately eventually have a limited capacity to accommodate that volume, right? Which will then equate to an increase in pressure as it would in any confined system. That can be compounded, though, by changes in the pulmonary vasculature itself. So over time, with sustained elevation and facing that flow, that will cause hypertrophy of the pulmonary vasculature, which will secondarily also increase that pulmonary pressure. We see this acutely in shunts like, AV malformations. The classic example is a vein of Galen, but chronically other shunts can lead to this phenotype too. Even PDAs over long periods of time with long time excessive flow can cause this phenotype. We think of it probably more often with chronic overcirculation from things like an ASD or VSD, causing pulmonary vasculature remodeling. And the mechanism by which this occurs is probably multifactorial. So in the acute phase, again, we're really just talking about the limited capacitance of any closed system and an elevation in pressure because of that. But over time, that excessive flow is probably contributing to remodeling via endothelial injury, which is compounded by oxidative stress. And with that dysfunctional and stressed endothelium, the development of like leakiness and interstitial edema too. And we see this play out not just in individual high-risk patients with high volume individual shunts, but it's probably trending on a population level as well. This is an example. This is a retrospective study that looked at preterm infants less than 32 weeks gestation and compared those with and without atrial septal defects and their eventual pH diagnosis. And they had a little over 300 babies in this cohort, and they found that those with an ASD compared to those without had a significantly increased risk of later developing pulmonary hypertension. And this figure shown as their Kaplan-Meier curve for time to pH diagnosis in each group. And I think vein of Galen, honestly, it could be a talk on its own, but because it's such a great example of acute flow-mediated pH, I thought I wanted to just briefly introduce it to you. The way we think of presenting is signs of pulmonary congestion and high output cardiac failure, but there's probably several phenotypes even within this one category of flow-mediated pH. And I put this slide up and I want to refer you to this really excellent table by Dr. Giesinger. This is from a small case series she published, but she took a lot of time to really go through the physiology, and I would encourage reading it in detail. It's a great review of the mechanisms behind vein of Galen physiology. But overall, the principles of management we think about require balancing the circulation really carefully so that pulmonary pressures are low enough to be avoiding RV failure, but not low enough that they make systemic still worse from the AVM or a PD if it's present. And this is, as in that example from Lakshman Narasimha in the Aitman article, they illustrate the extracardiac shunting of blood driving significantly increased right-sided flow. In this picture that they give us, the PDA flow is shown as left to right, but depending on the physiology in the moment, that shunt direction is actually variable. And we sometimes need to manipulate it, as we'll show in a very brief case example later. And To identify this category on echo, of course, identifying if there is like an AVM, that's obviously very helpful, but looking for other shunts on echo clearly can be helpful to you. But generally what you're looking for are signs of pulmonary overcirculation. So RV dilation, discordant outputs are useful. Another helpful marker though can be the eccentricity index. So while systolic eccentricity index is reflective likely more of RV pressure and probably more directly arterial pulmonary hypertension, the diastolic eccentricity index we think can be a marker of RV volume overload, and I'll show that in a picture coming up. To play. So here I'm just showing a clearly quite dilated RV. And here you can see a little TR as well. And we're also getting to the start of looking at that atrial communication, and you can check out that direction, which I'll show here as well. So there's a large atrial level shunt here. And then here's a clip showing you what I'm trying to get at with that diastolic septal flattening. So when you just look at this clip on its own, you do see that septal flattening, but you have to kind of slow it down to see where is that happening. So actually in end systole, if you go frame by frame, the septum is actually round, but at end diastole, when we slow this down at the widest point, we can calculate an elevated eccentricity index of 1.8. And again, that can be a sign of volume overload. And then I said I wasn't going to talk too much, but I just want to show a brief picture about a vena Galen case example. You can see, I wanted to show those clips. You can see reversal in the arch from cerebral steal, and then the clip below is showing, in this case, a large PDA. And in this case, we're working in this patient to maintain a right to left shunt to provide systemic blood flow. So, in this case, we maintained lower target saturations, and we gave allowed permissive hypercapnia to promote that right to left flow. And in this kind of case, certainly we wanted to actually avoid nitric. You can see that there's an RVSP in the 50s and the RV is dilated, but that's not the problem here. It's not pulmonary arterial hypertension that we need to relax vasculature. This is driven by the excessive flow shunting to that AVM, and we don't want to worsen that problem with the pulmonary vasodilator. So this leads us then into that general kind of management considerations for flow-mediated pH. And it's just really important to carefully think about what you're trying to support, and very important to be very judicious in offering a pulmonary vasodilator like nitric, which often would simply worsen your flow-driven pH and cause worsened overcirculation. So your primary management instead will focus on management of the shunt itself, often acutely diuretic therapy, and then interventional measures if they're indicated. Okay, next we're going to come to the left heart, or the postcapillary group. So this phenotype is driven by disease beyond the capillary bed on the venous side. So some of the acute pathology we think of is in cases of left heart dysfunction for various reasons, but they can also occur even further from the capillary bed, but chronically in patients with exposure to prolonged systemic hypertension, or more kind of immediately post-capillary in things like pulmonary vein disease. Like in flow-mediated pH, the pathophysiology is probably multifactorial depending on the disease. The general principle, though, is distal backing up of pressure at any point, which ultimately leads to that LA hypertension and then pulmonary venous congestion. This phenotype isn't very well recognized yet in the literature or even in clinical practice in neonates yet. This paper, though, came out of a group from Stanford in 2022. It's one of the few that describes a left atrial hypertension phenotype in babies. And this is in a cohort of babies with BPD and pulmonary hypertension. So they included 34 patients who were less than 2 years of age who had a BPD diagnosis and had undergone a cardiac cath. And they defined left atrial hypertension as a wedge pressure or an LA pressure of at least 10 millimeters of mercury. And they actually found that around a third of the babies in this cohort with PH seemed to have this post-capillary phenotype mediating their pulmonary hypertension. So not only did they find a fairly significant number at around a third of the cohort, these babies in that group seemed generally sicker. So they were more likely than the non-LA phenotype group to have more severe BPD, more likely to be small, more likely to need positive pressure ventilation, and notably also more likely to have both a need for tracheostomy and unfortunately death. So the authors wondered, to some extent, are these babies being treated in the right way? Are they missing out on maybe phenotype-specific pH care? Are we treating the wrong thing? Is that contributing to the worsened prognosis? So I think there's still questions to be answered, but this phenotype is starting to be increasingly recognized. And there's several markers we'll show that can indicate that postcapillary or left heart phenotype. So they include, obviously like things like LA dilation or markers of LV dysfunction using either your Simpsons or strain or finding mitral regurgitation, for instance. Diastolic markers on echo, briefly, you might think about a long IVRT, elevated E to E ratio, pulmonary A waves, things like that. Low LVO can also indicate this phenotype. And then atrial shunt direction can really be key here. So having a left to right atrial shunt should be a kind of a red flag to you if you have markers of elevated pulmonary pressure to be thinking about this phenotype. And here's an example. Clearly you're seeing some MR here. And then here's an example of LA dilation, both by clip and then by M mode. And just briefly as a reminder, at Iowa, we do a PDA score, and we would count an LA to AO ratio over 1.3 as dilation, but we technically think of actual calling LA dilation anything over 1.5 in that ratio, which you can clearly see an elevated or dilated LA in this picture. And then here's just a very quick case example. This was a term patient transferred for pH management with hypoxemic respiratory failure, and they were transferred to us on echo, on nitric. And on their echo, you see some kind of scary things to start. So you see, here's an RVSP in the 50s. You see a mostly right to left PDA. I mean, that's concerning. That might make you think that maybe you're on the right path on nitric. But then if we finish going through the echo clips, who's playing, you see how small and low that LVO VTI looks. Look at the direction of this atrial level shunt. And then by Simpsons and by strain, there was clearly some left heart dysfunction. So it's important you can't get confused, and just by seeing a TR jet, that doesn't mean pulmonary arterial hypertension. And in this case, this patient that had been transferred and was on nitric, we stopped the nitric. We needed the PDA actually to allow some right to left flow for better systemic blood flow. We added some inotropic support for the LV, and that baby clinically improved. Their lactate came down and their perfusion normalized. So these echo markers really guide what your therapy should be. So reducing afterload and supporting the LV with inotropy are probably the mainstays of treatment acutely in this phenotype. Antihypertensive should be considered, particularly ACE inhibitors like enalapril. They likely have a role in chronic postcapillary phenotype with LV diastolic dysfunction that is related to prolonged systemic hypertension exposure. And I put a quick cite down there. Dr. Stanford from our group here has a really great paper on this mechanism that I'd encourage you to look at. And, as shown as we were just reviewing the echo parameters of this phenotype, it's clear that generally pulmonary specific vasodilators in the acute phase are not helpful, as we need to make sure that we're allowing adequate forward systemic blood flow, for one, if there's a PDA, and two, the phenotype is not driven by inadequate pulmonary blood flow that you would need that pulmonary vasodilator for. So I think take-home messages from this portion of the talk: there are multiple phenotypes of pulmonary hypertension. Accuracy in identifying and talking about these phenotypes is really key, as management strategies are clearly very different in each group. And finally, just come back to the physiology and remember your equation for pulmonary pressure to guide your understanding and your care. So with that, thank you for that so much for your time. We'll conclude with the lecture portion, and I think we're going to move on to a Q&A next.
Fantastic. Thank you so much, Dr. Hyland, for this really great overview of some of the non-arterially based vasoconstrictive mechanisms of high P pressure. So that was really a wonderful review with the core concepts. So now we're open for any questions or comments. So please, if you can use the chat or the Q&A. For now, I don't have any flagged questions. So maybe I'll ask one question to kind of bring in some discussion. And then if we don't have any other question, we'll ask Laura to provide us with the link of the Zoom for the next session. Maybe Dr. Hyland, if you could outline a bit more what would be in your management pathway the role of, for example, PGE in some of these conditions. I'm thinking of, for example, those with vein of Galen, or patients maybe in which, like the last one that you outlined, with some degree of LV cardiac functional compromise, where maybe the duct needs to stay open because it's like almost like a single, a right
Yeah, single
ventricular kind of,
ventricular.
yeah, exactly. So I was wondering, where would you use PG in some of these contexts?
Yeah,
That would be great to hear. And
yeah.
do you think PGE may have also some effects on, like, that's a question I always wonder, like, could it vasodilate my
The
brain and
pulmonary
like
vasodilation. Mhm.
worsen like the vein of
Yeah,
Galen shunt? So
right,
yeah, I
right.
just wondered. Yeah.
No, that's a great question. And you're right, there's nuance to it because it's not just the PGE is not just the duct, right? That also you worry about the secondary effect of the pulmonary vasodilation we think about with PGE. So it's a great question. I think generally, we think about using a duct in the case of like univentricular dysfunction. When there's biventricular dysfunction, less likely to be super helpful to you. But in the case of LV dysfunction, if you have isolated LV dysfunction, I think that's a case where we don't always think about it, but you're right. You can kind of think about it like a hypoplast or a single ventricle type of pathophysiology and use that duct, but maintaining that flow from right to left to give you some additional systemic perfusion. That was like that case example I showed with the
Hmm.
baby that was transferred super sick to us on nitric. We needed to actually, in that case, initially the duct was left to right, the baby was not doing well. We took away those therapies to allow forward perfusion, and they improved. So I think, again, in cases of univentricular dysfunction, your duct can be helpful to you. And primarily in that case of LV dysfunction, again, we're just thinking about providing
Hmm.
improved systemic blood flow.
Thank you. There's a question from one of our attendee, which is, what would be the role of
Hmm.
vasopressin in a situation where you suspect post-capillary pH?
Yeah, that's a great question. And we do, and we're using probably more and more vasopressin in our babies that have arterial pH here. I would say that's typically like the classic reason if you have hypotension and resistance-mediated acute pulmonary hypertension, vasopressin can be your friend for hypotension management because we think particularly in times of high oxygen requirement, other pressors, but particularly norepinephrine, may have counterintuitively may actually be elevating your pulmonary vascular resistance as well. So we think of vasopressin maybe in the acute and short phase, maybe being a safer choice. And post-capillary pH, I would say it would depend on your underlying etiology, and you'd want to have your comprehensive echo assessment to tell you which pressor is needed. Generally, in those cases, though, if anything, you're going to be thinking about afterload reduction. So it would be probably more rare that you would need to be using vasopressin in that phenotype. But again, as alluded to, you need a comprehensive assessment and see what you're treating. But generally, you're thinking more about afterload reduction as opposed to raising with vasopressin.
Hmm. Yeah, the concern that you may make your LV even more struggle, and
Mhm.
if you have like severe LV hypertrophy that's causing your high LV pressure, maybe vasopressin could be kind of causing some issue to that. But anyways, another question for you in the chat that is, what would you think about the use of some of the medications like sildenafil or tadalafil if you have a concern of pulmonary hypertension in BPD?
Yeah, that's a great question. And that's kind of what I was wondering about too when I read that paper that I briefly referenced about the that there's a subset of like LA or post-capillary phenotype, probably in BPD PH babies. I think in that particular phenotype, it probably isn't the right choice. But in those babies that have more of our classic like chronic pulmonary vasculature remodeling, of course, I think that's probably more appropriate to what you're treating. So I think my answer is difficult, but it depends. It depends on what the echo shows and whether you have that resistance mediated or flow mediated or post-capillary mediated. They all need different treatments. And I think just blindly, just because you have BPD, throwing on a sildenafil, something targeting pulmonary vasculature is probably, I would say maybe not the best first choice.
Absolutely, to tailor to the pathophysiology that is being uncovered. Okay, perfect. We don't have any other questions for now. So I think what we're going to do, we're going to ask our panelists to copy paste the Zoom link right away before we lose it forever. Um, there's one other question. In the case of a flow hypertension, what would be kind of the cardiorespiratory strategies? Would you, include higher PEEP to avoid overcirculation, or are you concerned, I guess, that the higher PEEP would create issues with your afterload.
Yeah, I think that's a difficult strategy. I mean, I think meeting, appropriately in that, that U-shaped curve we think about, not over or under distending, is probably going to be your best bet from that standpoint. So I think you have to balance exactly what you said, Gabriel, the risk of
Mhm.
collapsing or over distending the lungs with that over circulation question. So
Yeah, I'm always concerned in vein of Galen when I come in and I see that they have these high mean airway pressure, and then this patient has like already like venous congestion, and
from the
so
stress, yeah,
and it's stressing the brain circulation even more with that because you're increasing your venous return pressure, and then you burst your vessels in your brain. So yeah, to be careful, I would say.
yeah.
Okay, great. So well, thank you so much for this really wonderful review and exceptional discussion. I'm sure there's going to be more in the next session. So I'll invite all the, first of all, panelists to take the Zoom link. Just before we close off, Laura did put the evaluation link for today. So please, please, please take a few minutes to just enter that. Um, and then the other thing that I want to talk about us all leaving for our next session is that we will have another session on October 2nd by Dr. Aisling Smith on the patent ductus arteriosus. And we obviously have the wonderful opportunity of attending the Dr. Regan Gissinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course. You have here the information that will take place from November 11 to November 14. It's virtual. The schedule is absolutely phenomenal. Really, this course will address so many of the core concepts in neonatal hemodynamics. So I invite everyone to register and join us for this wonderful course.